Hello, wonderful people. It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my pathology playlist. In previous videos, we talked about hypoxia, hypoxemia, hemoglobin abnormalities. We talked about cachexia. We talked about neoplasia, meaning tumors. We talked about benign tumors versus malignant tumors or cancers. Today, we will learn about the manifestations that are parallel to neoplasia. They can happen with cancer, hence the name Paraneoplastic syndrome. What is a syndrome? A bunch of manifestations that occur together in synchrony. For example, there are some manifestations that can happen in synchrony with lung cancer, others that can happen in synchrony with kidney cancer, etc. Click the like button, click the subscribe button, and let's get started. This is my pathology playlist. Please watch these videos in order for maximum understanding and retention, not to be confused with your patient's urinary retention. One of the most painful conditions in medicine, by the way. If your patient has urinary retention, please stop asking stupid questions like, "What do you do for a living?" and work quickly to intervene and relieve the retention. Otherwise, your patient is gonna kick you in the gonads. What is cancer? Well, back to basics. There are many types of cellular growth. There is hypertrophy, hyperplasia, metaplasia, dysplasia, and neoplasia. What if the cell is not growing? Aplasia. A means no, plasia means growth. Plasia means growth, hence plastic surgery, if you wish to make some parts grow or shrink. What is hypertrophy? Increased the size of the cell. Hyperplasia, increased number of cells. Metaplasia, meta means change, as in metamorphosis or the metaverse or the meta position in organic chemistry. So this is a tissue that is changing from one type to another within the same category, from epithelium to another epithelium, or from connective tissue to another connective tissue. Dysplasia, dys means dysfunction or difficulty. So this is defective growth, which can progress and become neoplasia. Neo means new, plasia means growth. This new growth, these tumors could be benign tumors or malignant tumors. If I say adenoma, this means a benign tumor of glands. But if I say adenocarcinoma, when I say carcinoma or sarcoma, I imply malignant tumors, also known as cancers. So adenoma is a benign tumor of a secretory gland, but adenocarcinoma is a malignant tumor of glands. How about papilloma? Benign. How about papillary carcinoma? Malignant. Lipoma is benign. Its malignant equivalent is called liposarcoma. But please be careful. The two words lymphoma and lymphosarcoma are synonymous and they are both malignant. It's the exact same thing, and it's a cancer. That's lymphoma, previously known as lymphosarcoma. What if the tissue is not growing? Aplasia. What if the tissue is shrinking in size? Atrophy. If you wish to see more pathology videos in the future, please drop this emoji in the comments, because it's the scientific study of the nature of disease. There is no Netflix and chill here. Instead, you get fever and chills. Neoplasia is synonymous with tumor, is synonymous with anything that ends in oma, except Oklahoma. A neoplasia is an abnormal mass of tissue, not normal, it is abnormal, whose growth exceeds and is uncoordinated with that of normal tissue. And even if you remove the stimulus that caused the growth, the neoplasia is going to persist and it's not going away. Tumors or neoplasias or anything that ends in oma could be benign or could be malignant. Malignant tumors are also known as cancers. If it's cancer of the epithelium, it's called carcinoma. But if it's cancer of connective tissue, it's called sarcoma. When it comes to cancer predilection, i.e. preference, carcinomas prefer to metastasize to lymph, but sarcomas prefer to metastasize to blood, at least in the beginning. Which tells you that even though cancer is weird, it is not completely random. Cancers are not random events. If they were random events, carcinomas can go anywhere they want and sarcomas can go anywhere they want. But that's not what the data shows. Cancers indeed do have preferences. Why do we hate cancers? Because a cancer is a growth with no control, with no limit, with no evident cause. We know of risk factors. Don't forget, correlation is not the same as causation. Well, my cousin developed cancer after using an HB graphite pencil. That does not necessarily mean that the graphite pencil caused your cousin's cancer. Cancer serves no useful function. It can arise from any type of cell in your body. And here is where it gets interesting. Some cancers do not secrete. Others secrete. There is a humongous comparison between benign tumors and malignant tumors, also known as cancers. And you can learn more about this topic if you watch my video titled Cancer Basics and the M mnemonic for cancer. You can find this video in my pathology playlist. Now, on to today's topic, syndromes, symptoms, manifestations that happen with cancers, paraneoplastic syndromes. Let's start with a type of cancer, which is renal cell carcinoma, cancer of the kidney. Kidney cancer is one of the causes of blood in the urine, also known as hematuria. Hem means blood, uria means urine. So what do we have in kidney cancer? If you've watched my video on renal cell carcinoma in my pathology playlist and in my nephrology playlist, I've told you that renal cell carcinoma is an inverted triangle. It's a triad of flank pain, flank mass, and hematuria. Does that mean that every single patient will have all three? Shut up. That's not what I said. This is the typical presentation, not the universal one. Risk factors for renal cell carcinoma include being a male, being an old male, and being a smoker. Having all three is the triple whammy. Besides the three symptoms of flank pain, flank mass, and blood in the urine, what else can happen? Well, there is an anatomical correlation and there is a pathophysiological correlation. Anatomical correlation is the renal cell carcinoma of the left kidney can metastasize to the left renal vein, and because the left testicular vein drains into the left renal vein, thanks to the cancer metastasis to the left renal vein, the left testicular vein will be unable to drain its blood to the left renal vein, which means the left testicle will swell and swell and swell even more. This is known as left-sided varicocele. Now, please get your pen and doodle with medicosis. I need two colors, red and blue. Here is the kidney on the right side, that's the right kidney, and here's the kidney on the left side. Don't forget that renal veins lie in front of renal arteries, just like that, the vein in front of the artery. Then what? The right renal vein is gonna drain into the inferior vena cava, just like this. Nice and easy. How about the left renal vein? Yes, it will also drain to the inferior vena cava. But because the abdominal aorta is on the left side of the inferior vena cava, this poor left renal vein has to pass through a longer distance until it reaches the inferior vena cava. And here is the lovely left renal artery behind the left renal vein. Okay, now we will imagine that the right kidney is gonna develop a cancer and the left kidney will also develop a cancer. Amazing. Then what? Let's suppose that the right kidney's cancer will metastasize to the right renal vein. Amazing, because don't forget, after all, the right renal vein drains the right kidney. Similarly, the left renal cancer will metastasize to the left renal vein. After this, let's draw the right and left gonadal vein. The right gonadal veins in males is called the right testicular vein, and in females, it's called the right ovarian vein. On the left side, this is the left gonadal vein. In males, it's the left testicular. In females, it's the left ovarian vein. Okay, then what? This is the right testicle, and this is the left nut that got cracked in nutcracker syndrome, also known as superior mesenteric artery syndrome, which I've talked about in a separate video on my channel. SMA syndrome is the disease that has cracked my nut, for reasons that are elaborated in that video. Back to our story. Right testicle drains directly into the inferior vena cava, but the left testicle, via the left testicular vein, drains to the left renal vein, Because the left renal vein is longer. Mnemonic, the left renal vein with the L is long with an L. And because it's long, it can collect from more organs. It can drain the left testicle because it's so long. But the right one cannot do that because it's very short. Now, if I have right-sided kidney cancer that metastasizes to the right renal vein, what's going to happen to my right testicle? The answer is nothing, because the right testicle is healthy and will drain directly to the inferior vena cava without being affected by the right kidney cancer. Conversely, on the left side, the left testicle is trying to drain. Okay, blood is going up. This is venous blood until we reach here. But this area is blocked by the tumor. It's blocked by this renal cancer metastasis. Now what? The left testicle will be unable to drain. All of that blood will pool and pile like this until the testicle swells. And this is called left-sided varicocele. If you palpate the left testicle of the patient, it will feel like a bag of worms. What's that? You are feeling the veins that are dilated and curly and twisty inside the scrotum. And you will find this on the left side only and not the right if the patient has metastatic kidney cancer. See, medicine makes so much sense once you understand what the French toast you're talking about. So all of that was the anatomical correlation of renal cell carcinoma. But what is the pathophysiologic manifestation or complication of renal cell carcinoma? This is what we call paraneoplastic syndrome, a syndrome that is parallel to the neoplasia, parallel to the cancer. And this syndrome includes, well, don't forget that normal kidneys secrete normal amount of EPO. But if I have renal cell carcinoma, I'll secrete a humongous amount of EPO. Too much erythropoietin equals too many erythrocytes. Lots of red blood cells, and you can call this polycythemia. You can also call it erythrocytosis. Is this polycythemia? The answer is yes. Is this relative polycythemia? The answer is no. It is not relative, it is absolute. The red blood cells are literally getting more numerous. It is not that the plasma is becoming more scarce. Is this an appropriate response from EPO? No, this is inappropriate. Because normally when you have too many red blood cells, EPO should go down. But not here. EPO will keep getting up and up and up, going up and up and up, even after you have too many red blood cells. So the negative feedback is not working? No, it's not working. That's the definition of pathology. So that's the first secretion. Second, this renal cell carcinoma can secrete parathyroid hormone-related peptide. Oh, so it's a peptide related to parathyroid hormone. What was the main job of the parathyroid hormone? You had one job, PTH, which is to raise the calcium. Yes, it has other jobs, but the main job is to raise the calcium in the blood. So this patient will develop hypercalcemia. And don't forget that calcium is contra-excitability. If you have too much calcium in the blood, you have too little nerve excitability. So the patient will have fatigue. The patient will be lethargic. The patient will be drowsy. The patient will be low and slow. Conversely, if you have low serum calcium level, hyperexcitability will ensue, and the patient will be super excited to the point of spasming into oblivion, what we call tetany. See, medicine makes so much sense once you understand what the French toast you're talking about. Why is serum calcium contra-excitability? Was discussed before in my video on nerve excitability, which you can find in my physiology playlist. And if that was not enough, renal cell carcinoma can also secrete AST, ALT as if it was a liver. Here is a tiny tip for biochemistry students. You will recall that some biochemical processes or pathway occur mainly in the liver and secondarily in the kidney. Does anyone remember gluconeogenesis, for example? Yeah, most of it happens in the liver, but the kidney can perform that function too. So it's not that shocking to find high levels of transaminases in patients with renal cell carcinoma. You can call these enzymes transaminases or aminotransferases. Now, if you're an excellent student, can you give me an example of another cancer that can secrete too much EPO as part of paraneoplastic syndrome? Comment below. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. If you want me to personally tutor you, reach out to me on my website. And that was just a quick discussion on renal cell carcinoma. If you want to learn about the other types of cancer, I have a playlist for that called Cancer. I mean, who in his right mind creates a playlist for cancer? Next, quick review on lung cancer. Don't forget that this is the trachea or trachea. Then you have right main stem bronchus, left main stem bronchus. Then you have bronchi and bronchioles. Ergo, bronchogenic carcinoma can have a paraneoplastic syndrome in the form of hypertrophic osteoarthropathy. Here is a lung cancer that for some reason is causing your bones to be damaged. Some types of lung cancer include squamous cell carcinoma and small cell lung cancer, among others. This squamous cell carcinoma with a Q sound will raise your serum calcium with a Q sound. How come? Because squamous cell lung cancer can secrete parathyroid hormone-related peptide, this doofus once again, which, just like PTH, is going to raise the serum calcium. But when the serum calcium is high, the natural PTH, not the PTH-related peptide, but the natural PTH, will decrease. So what should I learn about squamous cell carcinoma with the Q sound is that it raises the serum calcium with a Q sound, okay? What should I learn about small cell lung cancer when it comes to paraneoplastic syndrome? You will not need to know one fact, but instead you will need to learn 3 facts. Number 1, small cell lung cancer can secrete ACTH, adrenocorticotropic hormone, which causes your adrenal cortex to grow. And when your adrenal cortex grows, it secretes too much cortisol, and we call this Cushing syndrome. Not to be confused with the Cushing reflex or the Cushing triad. I have a video on that as well. Small cell lung cancer can also secrete antidiuretic hormone, which is a hormone that is anti-diuresis, too much urination, i.e. you will retain the volume in your body instead of urinating it. If you have too much water piling up in your blood, you end up with a syndrome of inappropriate ADH, and this causes hyponatremia. If you have watched my playlist on electrolyte imbalance and acidosis, alkalosis, etc., you will recall that serum sodium concentration, just like any other concentration, is a ratio. A ratio of what? Well, amount over volume equals concentration. So upstairs, I need an amount. What's that amount? It is the total body sodium, which is the amount of all the sodium in your body. And what should I put in the denominator? You should put a volume. Volume of what? Of water. Total body water is in the denominator. If I have a disease that causes secretion of too much ADH, syndrome of inappropriate ADH, I will retain all the water in my body instead of urinating it. So what's happening to the denominator? The denominator is going up. Therefore, what's going to happen to the serum sodium concentration? It has to decrease. And this will lead to severe hyponatremia. And let me give you a clinical pearl, especially on your exam day. Anytime the question mentions an old male smoker with a serum sodium concentration that is less than 125 milliequivalents per liter, this patient has small cell lung cancer until proven otherwise. And don't forget that when your patient is having serum sodium problems, he will suffer CNS problems. What do I mean by CNS problems? Neurological manifestations, lethargy, drowsiness, obtundedness, and even coma. Next, pancreatic cancer. As part of paraneoplastic syndrome, pancreatic cancer can give you Trosseau syndrome, not to be confused with Trosseau sign, which is what? Superficial migratory thrombophlebitis. What does itis mean? Inflammation. What does thrombo mean? Thrombosis. Clots. Clots in what? In veins. And what type of veins are we talking? Superficial or deep? Superficial veins. And it appears as if this problem is migrating. It starts here in my right leg, and then it goes to my left arm, and then left leg, and then right arm, for example. Also, paraneoplastic syndrome in pancreatic cancer can happen in the form of non-bacterial thrombotic endocarditis. If you want to learn more about endocarditis, I have a separate video on this topic in my cardiology playlist. What if I have stomach cancer? Oops. This can lead to a paraneoplastic syndrome in the form of acanthosis nigricans. Nigricans mean black. These are black velvety skin lesions on the back of the neck as well as the axilla. Now, what does the word acanthosis mean? Well, this has a specific definition in dermatology. If you know the definition, please comment below. Gastric cancer can lead to seborrheic keratosis, not one but many keratoses, and they happen suddenly like this. Also, believe it or not, gastric cancer can lead to nephrotic syndrome, and this will be a paraneoplastic syndrome. But it's not peculiar to gastric cancer. Lung cancers can do it, and breast cancer can do it as well. Next, a paraneoplastic syndrome known as Leser-Trélat sign, otherwise known as how the dermatologist of all people can diagnose a stomach cancer or a colon cancer before the gastroenterologist has time to get his head out of his sphincter. No pun intended. What is this Leser-Trélat sign? This is the sudden, dramatic, explosive eruption of multiple lesions that resemble seborrheic keratoses. What does SIBO mean? It's from sebum, that oily secretion, the sebaceous glands. What does Rio mean? Rio de Janeiro, river, flow. Oh, a flow of sebum. And the lesion is made of keratin. Oh, that's nice. Not if you are the patient. And this sudden, dramatic, explosive eruption of multiple seborrheic keratoses is Leser-Trélat sign. What does that mean? It could mean that your patient is having a visceral malignancy. In the good old days, this was called an occult tumor, something hidden deep within the crevices of the patient, such as gastrointestinal cancers, whether they are gastric cancers, hepatic cancers, pancreatic cancers, or colon cancers. The patient could have lung cancer, or breast cancer, or urinary tract cancer. Leser-Trélat sign is yet another paraneoplastic syndrome. So if you pay attention to your physical exam, you can diagnose cancer before anyone else. Who else is gonna teach you like this? Your professor with his PowerPoint? Give me a break. Do we have other examples of paraneoplastic syndromes in patients with visceral malignancies? Yeah, Trosseau syndrome, which is the migratory superficial thrombophlebitis, Sister Mary Joseph nodule, acanthosis nigricans, lymphadenopathy, Leser-Trélat sign, erythromelalgia, which we have talked about it in my video on polycythemia vera, which is a myeloproliferative neoplasm. Spider angioma could be a sign of an underlying malignancy. Ichthyosis acquisita, florid cutaneous papillomatosis, Coden syndrome, acrokeratosis paraneoplastica of basics, tylosis, and tripe palms. Do you think your doofus doctor with a stethoscope knows any of this? And then you wonder why patients are suffering. You cannot WebMD your way out of this. You have to learn what the flip you're talking about. Let me clarify some of these terms. Trosseau syndrome, not Trosseau sign, is migratory thrombophlebitis. What kind of veins? Superficial migratory thrombophlebitis. Sister Mary Joseph nodule is a nodule in the periumbilical area. Acanthosis nigricans is the dark brown velvety skin lesion on the back of the neck and the armpit, as I've shown in the previous picture. Do you want to learn about the story of Trosseau? Watch my video titled Trosseau Syndrome, which you can find in my playlist called Signs in Medicine. Today we talked about paraneoplastic syndrome, but what is pre-neoplastic syndrome? Comment below if you know the answer, and let me know if you want me to make a video on pre-neoplastic lesions. Do you want to learn about chemotherapy and how different chemotherapeutic agents work? Download my anti-cancer pharmacology course at medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you found this channel to be helpful, please consider supporting my channel by buying me a coffee. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website, medicosisperfectionalis.com, to download my courses, my notes, my cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, and physics make perfect sense.